Hi, I'm Karen Bears, acting assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington. I also work at the Seattle Children's Autism Center. Today I'm going to be talking about the RUBI Parent Training Program. So this is a program that my colleagues and I developed specifically for parents who have a child with ASD and co-occurring challenging behaviors. I'm going to be spending most of my time today talking about the program. But before I get started, I want to first talk about the importance of parent training as a treatment for ASD. I'll then go into an overview of the RUBI Parent Training Program and how we can make it work for families. I'll also do a brief presentation on research findings on the RUBI PT program, and finally wrap up with a discussion of how you can implement the program in clinical settings. So when it comes to autism, we have gotten much better about identifying and diagnosing children with ASD. The challenge is we now have this bridge problem where children get the diagnosis but then have difficulty connecting to quality evidence-based treatments. And so we have this issue of finding the services and getting access to them. This is compounded with the challenges parents have to go through in trying to find what is the right treatment for their child. So this is a slide I've actually been updating for several years now. If a parent were to go on the internet and go to Google, for example, and try and look up autism treatments to figure out how to help their child, they would end up getting 86 million hits that they would have to go through. And this is actually even more than last year, where it was 37 million, and even smaller, 9 million 3 years ago. So we know our parents are having to wade through a lot of information to figure out the best treatments for their child. So if you have a parent who adds evidence-based to the search term of autism treatment, this does reduce it somewhat to 6.4 million, but still lots of information that our families are having to wade through to know what to do that's best for their child. An additional challenge for treatments is most evidence-based treatments are costly, time, and personnel intensive. This really limits the ability to broadly disseminate them out into the community, which of course has implications for access for these families. So my colleagues and I firmly believe there was a pressing need for expanding the availability of empirically supported, time-limited, and cost-effective treatments for ASD. We essentially need more community viable treatments. Parent training is a promising approach that could help bridge this gap and help increase the access to time-limited services for families of children with ASD. Parent training has promise, first because it's traditionally a time-limited approach. It generally is a few hours a week that the parent comes in, and it's usually over 10 to 16 weeks. It also emphasizes the role of the parent as the agent of change. Finally, parent training has a very rich history as an established evidence-based treatment in child mental health, specifically for disruptive behaviors. So there's a lot to say that this could be an important and viable option for treatment for families. So why would we target parents? Well, first we know that in terms of disruptive behaviors, there's a high rate of disruptive behaviors in children with ASD, upwards of 50% of kids. We also know kids with ASD have adaptive skills deficits. That means that they're not doing on a daily basis what they're capable of. In fact, we oftentimes see this gap between the child's cognitive ability and their adaptive functioning. We also know that our families are experiencing high rates of stress and engage in high rates of accommodation. What that means is that they end up doing a lot of things for their children. For an example, I had a family whose child was cognitively and motorically capable of getting ready in the morning, but their morning routine involved having the child sit on the couch, the parent would put the TV tray in front of them, breakfast on the TV tray, and then proceed to dress the child as he watched cartoons. So this would be an example of accommodation. This child is capable of doing these skills, but the parent was doing a lot of work to support. Lastly, parent inclusion in treatment is not common. And this is interesting because it's a very common recommendation for a child who receives the diagnosis of ASD that the parent be an active participant in their child's treatment. But we note this is not necessarily translating into practice. I oftentimes hear parents talk about how they drop their child off at treatment and then maybe stay in the waiting room, or if it's in-home services, the child might be in one room while the parent's in another. And there's opportunities for consultation, but we wouldn't necessarily say the parent is an active participant in the treatment. So, our belief is parents really need support and are looking for support on specific instruction and on techniques to improve core symptoms of ASD, reduce challenging behaviors, and improve their child's adaptive functioning. So hopefully I've made the case that parent training is a good thing. Our parents are looking for this type of support, and we feel it could be very helpful. But parent training in ASD is actually quite complex. So I want to talk a little bit about what is parent training in ASD. So this is actually a taxonomy that my colleagues and I came up with to just help illustrate how complex parent training in ASD is. If you look at the parent support side of the taxonomy, you see that these are programs that are really designed to help support the parent's understanding of ASD, connection to services, and really the child is an indirect beneficiary as a result. So care coordination is an important part of a child's treatment program where we know kids are having to and parents are having to navigate many systems, medical, psychiatric, OT, PT, and care coordination is really about finding a central way to coordinate that care. Whereas psychoeducation is really just helping parents understand more about autism. What is the diagnosis? What is an IEP or educational plan? How can you best advocate for yourself? How do you make sense of all the treatments that are out there? This is really kind of knowledge-focused support that we can provide parents. On the other side, where you see parent-mediated intervention, these are more technique-focused programs for parents, where really the child is the direct beneficiary. When we look at autism, though, there's lots of areas that require focus of treatment. So you have your core symptoms of autism, so that might be language, joint attention, play skills. That certainly is one area that parent-mediated interventions are focused on. And then you also have your maladaptive behaviors. Those are those challenging behaviors we oftentimes see in children with ASD. So not just disruptive behaviors, but also things like toileting issues, sleep issues, feeding issues. And just to break it down one more step farther, we also have what are called primary PMIs and complementary PMIs. And what this means is there are some programs where the parent is brought in from day one and is the conduit to treatment. The therapist is working with the parent who then works with the child, and that happens throughout the course of treatment. That's different than complementary programs where the parent, or the bulk of the work is actually between the therapist and the child, and the parent might be brought in to help with skill generalization or consolidation, or again, the treatment might start with therapist and child, and then it's kind of transitioned over to the parent. But the point being that the parent isn't necessarily there from day one in the entirety of the program. And I have a couple of examples of programs under each of these categories. So Connie Cassry's JASPER program would be a primary PMI for core symptoms, whereas Early Start Denver model, as originally developed, would be a PMI for core symptoms following the complementary model. The program that I'm going to be talking about, the RUBI Parent Training Program, is a primary PMI for maladaptive behaviors and specifically disruptive behaviors. I also have the psychoeducation box shaded on the other side just as a reference for the randomized clinical trial that we did where we compared the RUBI PUT to a psychoeducation program. The last point is just at the bottom that with any of these programs that are out there, we see variations in format. So is it group versus individual? Is it telehealth? The location, is it in the home, the school, a community center? How intense is it? How long does it last? And even variations in the target age range for a program. So this is all just to say that when we look at what is out there for parent training in ASD, it is a very complex and multifaceted approach to treatment. So I want to talk now specifically about the RUBI PT intervention. The targets of the program primarily are to reduce the challenging behaviors that we often see in kids with ASD. So this includes things like tantrums, noncompliance, aggression, difficulties with transitions, but we also focus on adaptive skills. We know that sometimes those difficulties with having a child perform daily living skills can be tied to challenging behaviors. And that is that the child knows how to do the skill, but they are refusing to comply with or unwilling to do the skill. And so part of the idea is if we can reduce the challenging behaviors, that opens the door for us to focus on increasing adaptive skills. In terms of aspects to address ASD, this slide is here just to acknowledge there are lots of great parenting programs out there, such as Parent-Child Interaction Therapy, the Incredible Years program, Ellen Kasman's Parent Management Training Program. Our program certainly has a lot of the skills that are in those types of programs, but we're also very focused on adding aspects or including aspects that we know specifically connect to individuals with ASD. The starting place is that it's a program that's grounded in principles of applied behavior analysis. From the get-go, we teach the parents the ABC model, which is the antecedent behavior consequence model. That is the foundation of our program. And we use that information to help parents understand the different functions of behavior. Kids do things to get out of things, they get attention because they're trying to gain access to something, or sometimes it's just an automatically rewarding behavior. We also appreciate setting events. These are not necessarily specific triggers or antecedents, but they are kind of, I say, states of being the child might be in that increases the likelihood of challenging behavior. So a child who may normally be able to tolerate a transition, if they're feeling anxious, that transition might be more difficult, or the demand for that transition might be more difficult. Same with being overstimulated, tired, hungry, ill. These are all setting events that might impact child behavior. Again, we focus on decreasing behavioral problems, but also working on new skill acquisition. We appreciate that noncompliance isn't always just about being stubborn or strong-willed, but it can be rooted in rigidities and anxiety. And lastly, we're mindful of reframing implied behavior contingencies. And what that means is, the common statement of, if you do that again, you're going to get in trouble. That's vague enough that a child with ASD may have real difficulty understanding what is being asked or expected of them and what the consequence will be. So we really go into the program knowing that you can't really assume the child can infer what you're asking or what's needed, that we really need to be crystal clear when we have expectations and what the consequences are. So if you hit your sister, then you will lose your video games in the afternoon. We also have a very heavy emphasis on the use of visual strategies. We appreciate that children with ASD do much better seeing versus being told expectations. Those visual strategies or visual cues support understandings of expectations and routines. We also talk about functional communication training. It's the idea that behaviors are very communicative. They may just not be appropriate or functional. So part of it is understanding why a behavior is occurring and seeing if we can't teach the child a better tool to communicate their wants and needs. Lastly, because we know children with ASD may have difficulties with generalizing skills from one setting or one person to another, we do focus on skill generalization. And then what can we do to help maintain gains over time? So the RUBI program is broken down into 11 sessions that we want all families to be able to participate in. And you see it starts with teaching the ABCs. We move into some prevention strategies before we move on to consequence-based strategies, those teaching skills, and generalization and maintenance. There's also the option to do home visits and phone boosters, although I will say clinically we do in-person visits. We also have a subset of optional sessions. No one has to do these, but these are included to help address topical issues that we oftentimes see in our kids. So issues with toileting, feeding, sleep, timeout if it makes sense, imitation, token systems, or contingency contracting. The program itself was originally designed to be delivered to a parent, so therapist to parent, in weekly 1-hour outpatient visits. The treatment itself is very structured. It's manualized. There's therapist scripts. There's lots of in-session activities that we do, role play, video vignettes, and then at the end of every session, we have the parent complete or set up a homework assignment for them to complete over the course of the week. So it really is not just a passive learning process. The goal is to teach the skill, set up how the parent will apply the skill, and then have them go home and implement the skill. They come back the next week, we talk about how the homework went, we teach the next skill, add the next homework assignment, so it's kind of this compounding of strategies learned over time. So what is at the heart of the RUBI program? The starting place is that we really view it as a collaborative process in the program. We have our experts, our therapists, that have certain pieces of information or skills that we want to pass along to the parent. But we really make sure it's a family-centered approach. We make sure the targets of intervention are meaningful to the parent. We as the therapist don't tell you what to work on. We help you create and define what your targets of interest are and then create the plan around that. So it really is this partnering experience where we're teaching new skills and trying to promote behavior change. In terms of personalizing the program, really it's a family-centered, personalized approach. We think about designing and implementing each of the strategies in a flexible and a creative way, again, co-constructed by the clinician and parent. I say all the time, the parent is the expert in their child. I happen to know some helpful ways to help support the parent and child, and so we work together to figure out how we can best support the implementation of the skills, their use with the family and the targets that we want to work on. So we define what we work on based on family need, the child's age and level of functioning, what their primary behaviors of concern are, what homework they want to work on, and how we respond to challenges and barriers. Just a little heads up in terms of the research. An exciting thing about the RUBI program is we know it can work for a broad range of child ages, so from 2 all the way up to 14, 13, 14, high functioning, low functioning, and variety in terms of the severity of ASD. So it's a program that can really help a broad swath of children with ASD. So how do we know the program works? Well, the great news is we did a very large randomized clinical trial in the program. As I said, we compared the RUBI program to kind of Autism 101 psychoeducation. We had 180 families that were randomized to those two interventions, and our results were excellent, which I'll talk about in just a minute. And the findings of the study were published in JAMA in April of 2015. So the study again was 24 weeks of the RUBI program versus parent education in children with autism and co-occurring disruptive behaviors. And these weren't just mild, they had to have a decent amount of challenging behaviors in order to even qualify for this study. But they were randomized to one arm or the other of the treatment. We ended up recruiting 180 children ages 3 to 7 with ASD. The treatment was delivered one-to-one in 60 to 90-minute sessions in the clinic. And I will talk about how we have had to make modifications to the research protocol to make it more clinic-friendly, including that 60 to 90-minute session. In terms of primary outcomes, we had parent-reported measures, the aberrant behavior checklist, specifically the irritability subscale, as well as the Vineland, which looks at adaptive skills. We also had a blinded independent evaluator who met with every family, did not know what treatment arm they were in, and would at baseline ask, what are your two most important behaviors or issues you want to target? And they would ask about intensity, frequency, severity, and then every 4 weeks follow up. Okay, you said, for example, tantrums and noncompliance were your primary concerns. You said they happen 12 times a day. How is it now? And then again at 8 weeks, 16, 20, and 24 weeks. What the independent evaluator was looking for is improvement over time in the target problems. For our study, we didn't say a person was a responder unless they were much or very much improved. So we had a pretty high bar for what qualified for a treatment responder. In terms of outcomes, when we look at therapist fidelity and parent adherence, the short of it is therapists did a really good job of delivering the manual in both intervention arms. I think part of that is due to it being a structured manualized intervention. It's set up in a way to support the ability to stick to the treatment, essentially. We did a great job of keeping parents in the study. We had about a 90% retention. So 89% of families stayed in parent training, 91% stayed in parent education. I just have that parent education 91% bolded there because, again, that was our control condition. And yet we had all but 9% of our families stay throughout the 24-week trial. And I think, to me, this just reflects how interested and motivated our families are to get support in any way, shape, or form. So our parents, I think, were appreciative of while not necessarily targeting the challenging behaviors, at least getting that weekly support from a clinician and learning more about autism. For both interventions, the parents recommended other parents to participate. In terms of outcomes, what we see again is both treatments actually did pretty well. It's just that parent training did significantly better. We had about almost 50% decline in disruptive behaviors as measured by the aberrant behavior checklist at week 24, compared to about 30% for the psychoeducation group. And this is a pretty robust effect size, 0.62, which is a promising support or statement of it being an effective treatment. If you notice in the slide, there's a little line that kind of runs around right by week 16, and that's just to point out that the active intervention actually ended around week 16. Our goal was to get through all the core sessions and any supplemental ones by week 16. So we were kind of done teaching everything we know. We just moved into kind of a booster phase from week 16 to week 24. And what you see is, despite being done with active treatment, we continue to see a reduction in challenging behaviors all the way through to week 24. In terms of positive response to treatment, again, this is at any point in time, was the child much or very much improved? What we see again is both groups got better. it was just more pronounced in the RUBI Parent Training Program. So for parent education, we had about 40% of families that by week 24 were saying their child was much or very much improved, compared to almost 70% of parents in the RUBI program. So this is really exciting that we can essentially keep a lot of parents in treatment, and most will get better by the end of treatment. The other really fun and exciting finding, I think, is that we also saw changes in the Vineland daily living skills. So again, this is that measure of adaptive skills. What is the child actually doing day in and day out in terms of those self-help skills? And what we see is that the parent education group kind of plateaued or were a flat line from baseline to week 24, whereas the parent training group showed significant gains on a standard score on the daily living skills domain of the Vineland. And this is really important because when we look at standard scores, what we expect actually is that they kind of maintain or sustain at an even plane over time. This improvement on a standard score lets us know that these children were actually closing the gap. They were moving up the adaptive skills ladder over the course of the treatment. So in terms of highlights, at this point in time, the RUBI PT study is the largest psychosocial study, or randomized clinical trial in autism. We had 6 different sites, 23 therapists, 180 children, and we were able to show that parent training was superior to parent education. We also did measures of parent stress, caregiver strain, and we also saw significant reductions in those as well. I think very excitingly, we also showed that the improvements that we saw at week 24 maintained 6 months after treatment. So this is one of those interventions where we can feel confident that where we end is where the family should be. It most likely will be even months after treatment has ended. We were able to sustain those positive changes over time. So as researchers, your work is never done, and so we have continued to look at the program, look at adaptations of the program, and starting to now look at how the program works in community settings. So we recently finished a pilot trial of the RUBI program in a group format. We also actually just got accepted for publication our paper on piloting the RUBI program via telehealth, which had was very successful. We had great findings in that. That will be published in JAD, a Journal of Autism and Developmental Disabilities. In terms of dissemination and implementation research, we've been running the program clinically now at 2 community sites, and we are going to look and see how the program performs in the real world, and also how it works when community practitioners are implementing the program. So where do we go from here? This is our chance to kind of talk about what that clinical implementation looks like. So what I have are a couple slides that compare the research protocol to how we have been rolling the program out clinically. And what you see here is that clinically, we are treating a broader age range than what we did in the research trial. We accept a community diagnosis. We don't do the big assessment battery that you oftentimes see in research protocols. We don't have a cutoff criteria for the aberrant behavior checklist irritability subscale. In the research trial, they had to have at least a minimum level of 15, raw score of 15 or higher. Clinically, if a parent reports problem behavior, we bring them in regardless of their ABC scores. In terms of the therapists that are treating families, in RUBI, you had to be a certified therapist. And clinically, we could have therapists that are trainees and just learning the program. In terms of how long treatment works, in RUBI, it was the study, we were there for 24 weeks. Clinically, you're done when you're done. And then we just have a 1-month follow-up. Our sessions are kept to 60 minutes maximum. And in the United States, we're using particular billing codes for the sessions. So we are billing. Whereas, of course, in the clinical trial, we are paying people to attend. So that's a big flip, going from being paid to having to pay for the service. And the child may or may not be required to attend due to insurance requirements. So this is what our our clinical protocol looks like. We do a standardized assessment battery to just know who our clinic families are, and I'll show that in just a minute. We ask what their target problems or their target concerns are in terms of behaviors. We do the RUBI program, 11 sessions, and then up to 2 of those supplemental sessions, and we follow them using kind of abbreviated mid and endpoint outcome assessment. We then had them come back in a month, and we repeat that battery. So these are the measures that we are using clinically in RUBI. We're not using the ADOS or the ADI. That's not feasible clinically. We just do a parent report measure of autism symptomatology. We do a brief IQ. We have the parents fill out the ABAS. And then we have a couple of parent report measures of behavior problems, and then a measure of parent stress. And you can see the time point is when we have the parents complete those measures. So this is a little snapshot of what we've been learning thus far in terms of implementing the RUBI program clinically, again, compared to the research protocol. So the green line is our research findings on the aberrant behavior checklist irritability subscale. So families at baseline started around a ROS score of 24 and went down to about 12. The blue and the red line are two community clinics that are currently running the RUBI program, the Marcus Autism Center in Atlanta, Georgia, and then the Seattle Children's Autism Center here in Seattle. And what is really exciting is we're seeing very close parallels to what we found in the RUBI trial. In terms of pre-post change, all of those are significant. And again, I think this speaks to us starting to have some success in translating what was a research protocol into a clinical program. In terms of attrition, again, RUBI did great. We only lost 11% of our families in that research trial. In our clinical settings, it's hitting at about 20%, which still is actually quite good when we're looking at dropout or attrition in community clinics or community programs. So that is the RUBI program in a nutshell. What it involves, what are the different components, how has it been performing in terms of research, and how we're starting to see it work in the clinic setting. I really appreciate your time, and if you would like any more information about the program, we do have a website. It's www.rubinetwork.org. This website talks about some of our research, about the research consortium that's involved in this work, and also the manual is on there. I really appreciate your time. Thank you for joining me today.